if we will post it. But if you have any objections or concerns about that, please let us know, and we won't make any sudden moves without knowing that everyone is comfortable with that. Because there's so many of us, we didn't think it was a good use of time to go around with formal introductions, but we ask that when it comes to the open discussion, if you want to speak, please introduce yourself first. We did send out a very brief bio of who each of you are, and many of you know each other, but please do let people know who you are and where you're coming from when you speak. While Don and Henry are speaking, please feel free to use the chat function to either signal, let Sam and me know something you think we should know, or to offer up questions that Susan can call from. Of course, you should feel free during the open discussion to just chime in or raise your hand, whatever you're comfortable with, and Samantha and I will be monitoring that. And I think that's it for housekeeping. So with that, let me introduce our moderator. Susan Dentzer is currently a senior policy fellow at the Margolis Center for Health Policy at Duke University. She is one of the nation's most respected health and health policy thought leaders. She has been a celebrated healthcare journalist for many years with PBS, NPR, multiple other publications. She was also an editor for Health Affairs, which is a leading policy journal. Susan has led many organizations in healthcare and beyond in the past, so she is a seasoned executive and she has a keen eye for what matters most in a given conversation. She is an elected member of the National Academy of Medicine. So we're so grateful that she was willing to do this with us, and I think she'll be a great shepherd. So Susan, let me turn it over to you.
Thank you so much, Mai, and thank you for those very kind and generous remarks. And it's a delight to be here as you venture off into this very important new territory that not new to you, of course, but new and so important for so many as we contemplate all of the needs and the opportunities to deliver better care to those with intellectual and developmental disabilities. So it's an honor to be serving in this role with you today. Our goal today is to have a genuinely immersive experience with a deep dive into the thoughts of two preeminent thought leaders, as Mai said, leaders first and foremost, and thought leaders equally importantly. They're going to frame both the moral as well as the policy and political issues around caring for people with intellectual and developmental disabilities. So we will have this wonderful immersive experience with them and also afford all of you a chance to pose questions to them, as Mai said, to share your own observations and reflections and to get to know one another as well, those of you who do not already know each other. When I think about Don Berwick and Henry Claypool, I'm reminded of a convention that the Japanese have, which is to name certain people, certain important cultural figures, living national treasures, as a way of honoring them in life for the lasting contributions they have made to the culture and to society. And I can't think of two people in the US context who fit that bill. Don and Henry are living national treasures. Let me tell you a bit more about them both now. Don, of course, is a former administrator of the Centers for Medicare and Medicaid Services. He served in that capacity in the early years of the Obama administration. Before that, of course, he was president and chief executive officer of the Institute for Healthcare Improvement, a not-for-profit organization based in Massachusetts that has been a seminal force in improving the quality of healthcare in America. But beyond that, Don has been a leader at the National Academy of Medicine and some of the extremely important reports around medical errors and quality improvement in healthcare. Previously, he has studied the management of healthcare systems, with emphasis on improving healthcare by relying on the evidence in many respects. And of course, at CMS, he was instrumentally involved in making healthcare better by virtue of oversight of the Medicare and Medicaid programs. Just as a testament to Don's contributions at the international level, many of you will know he was knighted in 2005 for his work creating new care models in 5 of the trusts within the United Kingdom's National Health Service. And if we were in the business of knighting people here in America, he would have been knighted long ago for his work to improve the health and healthcare of so many in our country. The other living national treasure I mentioned we have here today is Henry Claypool. Henry is currently serving as the policy director for the Community Living Policy Center at Brandeis University in Massachusetts. And before that, he was a founding principal deputy administrator of the Administration for Community Living at the Department of Health and Human Services, also in the Obama administration. Let me just quote what a colleague once said about Henry, because it bespeaks Henry's many contributions. This colleague said of Henry, he's not just a leader and an advocate, he's the kind of colleague who opens your eyes, makes you see the world differently, makes you think about policy problems you didn't realize were there and solutions you didn't know existed and that you yourself should be working to advance. And I'm certain that Henry will perform in exactly that role today. Earlier in his career, he was appointed by President Bill Clinton as senior advisor to the administrator for the Centers for Medicare and Medicaid Services. He helped streamline a number of CMS programs at that point and ensure that Medicaid and Medicare recipients who were disabled had their concerns heard by the agency and by US policymakers. He then left CMS to establish Advancing Independence, Modernizing Medicare and Medicaid as a co-director, advocating for a number of important policy changes at that time, including changes in the homebound restrictions of Medicare. So as you can see, 2 people with just unbelievable knowledge, depth, experience, lived experience in the worlds of healthcare, care for the disabled, care for the vulnerable, care for those less fortunate, and always thinking of ways, as Henry's colleague said, to imagine a different world, and a different world that is made possible through the interventions of people at the policy level and in the moral context as well. So with that, we're going to turn to their comments and reflections now. And Don, we will start with you. Reflecting on your past experiences at IHI, as a pediatrician, as a policy leader at CMS, you've been doing a lot of thinking about the moral determinants of health, in addition to the more conventionally referred to social determinants of health. Give us a sense of how we should see the issues of IDD through this moral determinants lens.
Well, thank you, Susan, for the very generous introduction, for the chance to comment. And I want you to know what a privilege it is to get to be part of the board of IEC and to help this organization. It's really important. And I have to say a word about Henry. I got to serve with Henry Claypool in the Obama administration. And, you know, when I think of public service, there are people who just move you deeply by their level of commitment and mastery and generosity of spirit. And Henry is every bit of that. And it was an honor to work with you, Henry. I look forward to hearing your remarks. I thought, building to your question, I'll go back in time a bit. My first real interest in IDD goes back to my high school years. I don't remember why, but I became involved as a volunteer in high school with the inpatient ward for autistic kids at a hospital, Middlesex Hospital, which was 17 miles from my home. My father was a general practitioner and he rounded at that hospital, but there was a mental hospital in that same town. And I ended up going there many weekends as a volunteer to just play with, really, and get to know these kids with autism. I don't know what was about it, but it was sort of a magic experience for me. It shaped me for many, many years thereafter. Something very compelling about these kids, and I must say their families, and I'll say more about that in a minute. But I became fixed on the problem, so much so that when I was in college, in my Harvard college years, my senior thesis was about autism. I got the chance to meet and work with Bernard Rimland and others around the country who were pioneering in their thinking about that condition in those early days. And I developed a randomized clinical trial. With about 20, 26 or 28 autistic children, I worked with the association and found the parents incredibly generous. Here I was a kid. I wanted to do a randomized trial of a therapeutic intervention as a college senior, and they couldn't. They were so generous to me. The words they used were, well, you know, we're going to beat this by committing to help investigate what to do. So I did a randomized trial, and it was a very eye-opening experience. When I became a pediatrician, I already had this very much in my mind. And I'll tell you, as a pediatrician, it doesn't take long in general pediatrics to run absolutely dead center into the issues that IEC has formulated to improve. Many of my patients were kids who had these needs, and it was beating your head against a stone wall to try to get a healthcare system that just was not configured for a kind of whole of life approach to support, just trying to milk resources out of the communities and schools and organize around the kids. As again, one of the properties here always was the parents as allies and colleagues, because it's the parents that actually were doing the hard work of mobilizing the resources that we were trying to get to bear on those kids. And I've never forgotten that era of my work, 20 years of practicing pediatrics and trying to solve these problems. And very much when I went to CMS, this was on my mind. At CMS, thanks to the Affordable Care Act, the door had opened to a whole bunch of new possibilities for home and community-based supports, for longitudinal care, for a sense that we could actually reach out across time and space for people who need it. And an investment in innovation. I got to set up the Centers for Medicare and Medicaid Innovation, which to me is just a remarkable comment on what government can do when it invests on behalf of people to make their lives better as an investor, not interested in quarterly returns or the IPO, but just, you know, where are we going to put resources that will actually help people? It was a great privilege. I guess for me, the moral side of this is maybe a little unexpected, but this is bigger than developmental disabilities. This is about whole person care. And my wife, who's in the field of energy and environment, used to teach me about what she called charismatic species. She meant, like, if you want to change the world with respect to environmental stewardship, do something with grizzly bears, not squirrels. Some things just test the system and draw attention. This is such a case. I think what IEC is about is so important, not just for the children and adults we're going to talk about in this meeting, but for the whole idea of organizing healthcare around the lifelong needs of people. Right now, I have the advantage of chairing a National Academy of Medicine committee on traumatic brain injury. Not the same problem diagnostically, the codes are different, but when people have traumatic brain injury, and it's a vast burden in this country, they do not enter a system capable of helping them through their lifespan in all the dimensions of help that they need. And it's almost identical to what Mai and her colleagues and we are talking about in IEC. Can we build care around people? And that's how I see this. And that's the morality here, which is, are we going to be inclusive as a nation, compassionate? Are we going to try to understand journeys and reach out to people in difficulty through their lifespan? And to me, that's a moral question. We haven't built it right. And the amount of change involved in getting us to a continuous care system is massive. against tremendous political and financial obstacles, but it's why we're here. And so I thank Mai and her colleagues for having the vision to start this. I think we're developing something really, really important for many more people than just people, the very important people that we're talking about today. There's a professor at Berkeley, John A. Powell, who talks about targeted universalism, which I'm intrigued by his theory. What he says is if you build the systems for the people who really need them, if you build the care and compassion and assistance and outreach and generosity that people who are in trouble need, you help everybody. And this is a case in point. So anyway, it's a privilege to be with you. I don't know if I've given you enough of an answer, Susan, but thanks for asking, and thanks for being here with us.
You have indeed, Don, answered that wonderfully, and we'll come back to this very important thought about configuring the healthcare system for a whole of life approach, and that wonderful phrase that you just used, targeted universalism, as a means of doing that. So to you, Henry, as we've discussed, you're a person who has actual lived experience of life with disability. You have served in the policy world, as Don mentioned as well. You have truly walked the walk of a person who understands these issues from the inside out. Give us your reflections on where you think we are at this moment in time with respect to those with IDD, and how we get to the system, the type of system that Don is describing and that you yourself have worked so hard to try to achieve, truly configured around whole person care.
Sure. First, thanks, Susan, for that introduction. I feel like I should stop now and leave you all with the impression that I am a treasure here. So I'll try and keep that with me. And Don, to you and the privilege we had to serve together in the Obama administration at such a critical time. And to think today that we still hold on so dearly to the Affordable Care Act, Obamacare, as it's called, knowing how close it came to being upended. I just am so glad that our service, was for something and continues to help people today. And for the group, I wanted to really just share some personal experience. So forgive me, you're going to go on a little journey with me, but hopefully my lived experience can give you some insight into how we really do need to rethink some of the policy areas that we're working in, and how much real people's lives should be tapped into to inform that policy development. First, I just really need to say this clearly. This Medicaid home and community-based services is what I describe to my colleagues in health policy as the backwater of health policy. It really isn't well understood. The federal government doesn't have a very large role. It's the domain of the states, and yet it's where so many beneficiaries live their lives day in and day out. And we have real challenges in this system for it to ever be able to operate on par with a hospital system or a more clinically oriented healthcare delivery system. So it's really refreshing to see a large investment proposed in HCBS, and I'll try and get us back around to how my story kind of informs that. But I think it's first important to understand that I acquired a disability. I was a sophomore in college at the University of Colorado studying chemistry, was going to be a physical scientist, and then that didn't seem like something I wanted to continue to pursue. Struggled to figure out what that was. Graduated with a degree in geography because I have a great passion for maps, and did very interesting things with remotely sensed data and geographic information systems. But none of that really came to bear on my career. So, or maybe it did. My first job after my undergraduate was at an independent living center. So basically an entity that is set up to help people with disabilities get better information and access the services that they need in their community. We happen to have run a kind of a home health agency there. And I was at the time a consumer of those services. So I was quite intimate with the personal care needs that we were delivering. And it became very clear that we had a system in that Medicaid was paying for that paid for community-based services that was overly reliant on clinical supervision. And so a movement kind of evolved in the, I would say this is in the 1990s, primarily early 80s, where people were directing their services. And that relates back to this Medicaid home and community-based services portfolio, right? The personal care issues, et cetera. Now, at the same time I was doing this work at an independent living center, I had a real opportunity to learn about intellectual and developmental disabilities. I served on, every state has a developmental disabilities planning council. And I actually served there for about 8 years, or maybe not quite that many, but came to chair it, but learned quite well the parallels between my experience and those individuals and families living with IDD, and how we could move together to really reform this community-based system that we all depended so much on and really identified so closely with. So it was a great learning experience there in the early years at this independent living center and on the Developmental Disabilities Planning Council. I then got pulled away to work at the University of Colorado, the Boulder campus. If you've ever been there, it's not very accessible. This is post Americans with Disabilities Act passage. And so they had really significant challenges making their campus physically accessible and programmatically accessible. And why I share this is because the political environment in academia taught me so much and prepared me quite well for what would come next. And that was, I was asked to come to Washington and serve during the Clinton administration. But the 5 years I spent at CU Boulder really prepared me well for what I would encounter in Washington in this kind of policymaking environment. So I was consider myself quite fortunate there. During that time, there was a Supreme Court opinion that came down called Olmstead, which, if you're not familiar with it, it really has, I think, reshaped how we think about providing services to people with particularly intellectual and developmental disabilities. Before the decision, it was clear that, you know, operating large institutions had kind of run its course, but states were still experimenting with the model, trying to refine it. They'd become dependent on it. Families had a preference for community-based services. And for those of you that are familiar with the Medicaid program, know how mightily many of them struggle to actually get access to community-based services through a waiver program. But these large institutions really do require a lot of money. And so it helped having the Olmstead decision hanging over states to really rethink how they were going to accelerate some of the reforms that were already underway, right? It was more cost effective to serve an individual in the community than sending them to an institution. And so that had obviously been realized by states. But this Olmstead decision really crystallized it because it cast it in terms of individuals having civil rights. And that was new. And Medicaid still to this day really struggles with where are these lines and how best can we operate this part of the healthcare delivery system in compliance with one's civil rights. So I was, again, very fortunate to be there when the guidance for that was developed. This was late, it actually came out in 2000 and really did kick off a number of fairly modest reforms, I would say. But when I was working on them, I thought they were huge and really significant. But the reality is we were still kind of tweaking around the edges and making inroads and giving states new options. But when you reflect on where the money is spent and how many people are being served and how they're being served, you can really see how much work there is to do. So I could recount for you the incremental changes that occurred during my time in Washington, but I don't know that that's really that important. I do want to come back around to this investment in caregiving that the Biden-Harris administration has put forward, because it really is a magnitude greater than anything I've ever really thought about doing. And knowing that trying to implement or trying to spend that much money in the existing home and community-based service system would really be a challenge, a welcome challenge nonetheless. But there are some things that need to happen before the money would be spent in a way that wouldn't exacerbate some of the disparities that we now experience. And these disparities in access to care are up between and among disability groups and across states. So the way states operate these home and community-based services programs vary so greatly that there's real level setting that needs to be done to bring them into greater alignment so that one could have a similar experience in a Louisiana to what they might experience in a state like Washington. So there's much work to be done, and thinking about having $400 billion to spend, is really appealing and quite interesting. And I would say the moral imperative here is really making prudent investments in trying to build two things: the capacity of the states to manage these programs better. And if not, then maybe one day it will be federalized and there will be an opportunity for the federal government to be more involved in making sure that these systems operate with greater uniformity. That doesn't appear to be in the cards right now. And secondly, I'd say the provider networks are woefully under-resourced. Many of the providers that get into the home and community-based services arena do so because they have a value-based proposition that they're wanting to contribute and give back. Unfortunately, many of the providers in this area don't operate as a kind of a traditional business, or when they do, they don't have sufficient margin. Remember, we're talking about Medicaid reimbursement, and it's not sufficient, I would argue, to really develop the type of home and community-based system that could attach itself to what many of us in the disability community refer to as kind of the medical model or hospital and physician services. And we have to find ways to bridge these two. And making this investment now would be great, but I think there's a real need to have groups like IEC thinking about how can you use traditional payment mix to help fund providers and systems so that you can actually take the money that's on the table and do a better job, because I'm not sure that we're going to see the federalization of the HCBS and the kind of diminution of the inequities that exist across states and within these disability populations. It's largely going to, I think, be led by some interesting partnerships with clinical types, with those that toil in the fields of community-based services. And so I'm really pleased to help Mai and others that are working on these, because it really is the necessary and important work. But with that, hopefully it sets up some questions that you all have or that Susan has. Thanks.
Thank you, Henry, and thank you, Don. And I'm struck by the commonalities in both of your observations. First of all, your combined lived experiences. Don, as you said, as a younger person meeting and helping to serve kids with autism at Middlesex Hospital, working in the context of creating that randomized controlled trial with such kids when you were at Harvard, and then going on in your world as a pediatrician and as encountering so many of those children in your practice, and recognizing how far short the healthcare system fell at the time, as it continues to do now in terms of meeting their needs. And again, your reference to the fact that the healthcare system to this day is still not configured for a whole of life approach that would understand the lives of these children in their homes and communities and organize care around them, as opposed to expecting the reverse. And then finally, again, your reference to targeted universalism. If we can make the system work well for the least advantaged and most vulnerable, it will arguably work well for everyone, is such an important point. And as I say, tracks so well with Henry's experience as a person with disability, acquired disability. So he lived the life, both sides of that life, the life without the disability and then with, and came to understand in a very, very visceral way the challenges for people in a system that is not configured to serve them and meet their needs. And Henry, your story of how you even worked in the context of the Olmsted decision to really bring the issue of civil rights into this discourse, as well as the court decision so clearly did, and help to create a healthcare delivery system and a long-term care delivery system that is in compliance with civil rights, is such an important development in our history, and obviously one that continues to unfold. I think, Henry, your observations just a moment ago about the Biden administration proposal to expend $400 billion over 8 years to build up and to some degree revamp home and community-based services is really a point of departure now, I think, for some questions I'd like to pose to both of you. And it really goes back to the notion of truly creating systems configured around people. And obviously this probably 20-year trend the country has been on to begin to move in the direction away from institutional care to more home and community-based services, to put resources in the hands of people more and more to enable them to make decisions about the structure of their care and support network. All of that is extremely laudable in general terms. As you pointed out, Henry, there still are real obstacles to making these kinds of systems a reality. And I guess I'd like to start there and build on some of the comments that you made earlier, which is this proposal was put forward with the best of intentions. It's obviously already encountering, having been married to the infrastructure proposals of the administration, it's already encountering pushback from people who insist that this is not infrastructure, even though in the lives of people with disabilities, clearly this is infrastructure. that will enable them to live their lives. But again, to your point about the challenges of really operationalizing this and equalizing the opportunities across states, as you said, and in the context of the Medicaid program in particular, this is going to be, even if the dollars are eventually appropriated, making these new systems a reality is an extremely tall order. So let's start there if we could. If we think about the kinds of work that IEC can do to propose policy initiatives that will light the way to using these resources effectively and creating these really functional systems, what do you think are the potential contributions that IEC could make that will be heard in the Washington policy community? I want to start with you first on that, Henry, and then Don will go back to you.
Well, for me, it's, what I've learned in my experience working in health policy, because I describe myself as someone that works on disability policy, but I've spent a lot of time working with these systems. So just to answer it directly, I think what we're looking at is a real need to ensure that we can actually make appropriate investments in people's lives outside of clinical settings, in their homes and in the community, that will yield certain outcomes that people with payment models that are people that are on top of responsible for paying for services will buy into and believe that this is a good investment. And what always comes back around to bite us is the need to show evidence that investing in these community-based services really has a direct impact on somebody's health outcomes. And that's been a struggle. And so I think that's one of the central features that needs to be addressed. And I know that Dawn and I have thought long and hard. So hopefully that sets them up for building on some of this.
Don, do you want to pick up on that? What are these policy thought leading opportunities that IEC can avail itself of and make a contribution to?
Several. First, and I think Henry and Maya and others are certainly better able to be to comment on this, but I think that we have to innovate our way to the solution. This is very hard stuff, and I don't think we know exactly what can help a person with multiple needs like we're talking about. So I'm a big fan of continuing to invest in innovative models and see which models are working. So remain curious and investigatory about the answer to your question, both about policy and delivery system design. I would think the core modifications we'd have to do with moving from transactional funding to relationship funding. That we simply have a system that is still basically widget oriented, an encounter, a visit, even a bundle. When what all people, not just people with challenges, but especially people with challenges need is someone who has a memory over time and space of where they are, what's next, what they need, and where they're part of the solution, where the person themselves is very powerful in that context. We don't have policy or payment that actually establishes this kind of relationship-oriented integrator role, and I think we badly need it. I personally think getting out of fee-for-service is part of the answer, and into more holistic funding for the care of individuals. We have to be able to move money into unusual places. What a person with a developmental challenge may need may not lie exactly within the four corners of a healthcare organization. It may be adjacent to it or in the community. The money has to follow the person, so to speak, and those person's needs. And again, we need an advocate, an integrator that has the holistic funding. For IEC, there's advocacy for that, but also I think there are design challenges here. I think, so let's say all the money was there, and Henry's saying we may have more than we could spend right now. What is the ideal design? Take a person with a developmental disability at various levels of need. What would that perfect system look like? we're struggling with that now in the TBI, Tronic Rangery work we're doing at the Academy. We know what's wrong, but it's not quite clear what's right and how to set up a system that would be truly continuous. There's one other edgy piece here that I'd love to hear Henry reflect on, and that has to do with fraud and discipline. This is a sector in which there is a concentration of bad actors, not many, a very few, but they kind of pollute the water, the atmosphere. And so strangely, part of the solution is going to have to be some ways using surveillance and diligence to make sure that when someone's in this game, that they're actually playing it fairly and fair and straight. So those are some of my answers.
Great. And we have some wonderful perspectives coming in from the chat from our assembled group. So let's just share a couple of them here. In fact, James Perrin basically says Henry is giving strong arguments for taking Medicaid out of state budgets and making payment at levels at least those of Medicare. That's obviously would be a structural consideration of some sort. Then Adam has weighed in, if the direction continues to be state-led, how do you see states embracing the responsibility and driving advancement in serving those in their states? So let's pose those two questions to both of you. Why don't we start with the notion of essentially, again, taking, I'm not sure specifically, but taking Medicaid out of state budgets, or essentially taking this particular group of services out of Medicaid. I'm not sure how to interpret, James, your question. Perhaps you want to come on and say a little bit more about exactly what you mean, and then we'll pose that question to Don and to Henry. James, are you with us? Are you on mute? Okay, let's go to Adam.
Yeah, Adam Hjerpe.
Yeah, I was just getting off mute. It's interesting, and maybe James was talking about the idea of almost like you see dual special needs programs that actually they traverse Medicare, Medicaid, as he's saying something like, if you take the IDD or LTSS programs and you federalize those or elevate those up, you actually extract them out of the state and kind of do a quasi-state federal, I don't know, cooperative to get those services provided with more standardization and better kind of investments. It's interesting.
Could be.
I'd just quickly say in response that, yes, to Don's point about moving away from fee for service, because if you really think about building a similar kind of home and community-based benefit in the Medicare program, with appropriate reimbursement rates to sustain these kind of fee-for-service companies that will come up, it's staggering to think about what the CBO would actually score that at. We're having a tough enough time getting a decent score out of CBO, working with Medicaid and people with lower incomes. So we know there's a lot of functional need out there in the population. And so I do think that really looking to models where the funding is available and people are able to get a capitated payment and their needs are able to be met, is the ideal. It's just moving from the system that we have today and getting to that place where we really do have proper payment and models that are robust enough to really take on people. We've been toiling in the dually eligible space for a while, and we keep iterating on the dual SNPs. We have FIDE SNPs. We have all kinds of variations now in how to slice and dice these payment arrangements, and it's still challenging. So I do think that there's work to be done there, and I would argue that that route is probably going to be essential given the amount of money that it would take to really operate a kind of fee-for-service system in Medicare.
Adam, you put another intriguing question in the chat, and I wonder if we could ask Don to comment on this. Don, as you mentioned, you had the privilege of being there at the creation of the Center for Medicare and Medicaid Innovation, CMMI. And Adam is asking, could a wave of new and innovative payment models be a vehicle of opportunity around whole person care and advancing the application of resources, the investment to improve the results, outcomes for the lives of those with IDD? What is your thought on that, Don?
Absolutely, Adam. Some basic rules or basic maybe principles I might try to sell in this country would be simplicity and flexibility. Right now, we have a highly complex system of payment where money moves among agencies, as Adam and others have mentioned, the state-federal relationship. It's just very complicated, and it makes everything opaque. You can't tell where the resources are. I think there could be an argument for federalizing Medicaid itself, the whole program, which would take away tremendous layers of complexity and transaction. But the other is flexibility, and that is developing models where responsible helping systems have a pot of resources, an adequate pot, that they have an infinite flexibility to use on behalf of the people who have needs. No one on Capitol Hill is smart enough to figure out exactly where the funds should go to support me if I'm have an intellectual development disability. It has to be a localization. There has to be locality control. And that would require flexibility at the local level that our current coding systems and multiple sources of funding and fee-for-service just don't allow for. So yes, I think there could be a wave of these innovative payment models. And Adam, again, I would say CMMI, if I could remember, it has two M's, not one.
Yeah,
would be really cool because it would be quite possible to do very exciting. And by the way, promptly informative models of changing the flow of money. Ari put something in the chat also that Henry may want to comment on too, but he's asking, well, what about competence? What about at CMS? Is are the capacities developed to deal with some of these administrative challenges? The answer is no. CMS, Congress is mostly concerned about Medicare, and so actually arguing for resources and thinking about Medicaid is very tough. And I would say part of what I like to see is a beefing up of the clinical and intellectual supports at CMS around these Medicaid issues.
And further, Don, Ari notes that there's a gap in expertise on the IDD side in particular. Do you agree?
Yeah, it's a consequence of that. A lot of energy goes into the Medicare side. Let me not say anything, I don't want to be misunderstood. The Medicaid units at CMS are wonderful, absolutely thrilling to work with, terrifically dedicated people. But Ari's kind of right, to develop even more capacity there for dealing with the IDD issues could only help.
I want to come back to a point that Leslie Feinberg put in the chat about assessments, and I gather this in the context of assessments of programs and outcomes for individuals that are focused on social determinants of health and the person's quality of life. Leslie, do you want to say a bit more about what you mean there, and perhaps pose a question on that, either Don or?
Yeah, sure. Thanks, Susan. What I'm trying to get at is the concept that folks with IDD, if they're in a system, pick a system. I'm going to choose OPWDD because that's where my kid is, and if he's constantly being assessed, and the assessments are meaningless to him. The assessments don't provide any insight into what he needs and what will continue to help him move forward. And the assessments always end with a fear that if he's meeting even, like 1/10 of a goal, that they're going to pull back services. So can CMS create some sort of assessment that values the person's life? Talking about a quality of life and talking about the needs of the individual without really giving them the opportunity to feel good about the things that they do succeed in. it's a craziest system. And I applaud this group for trying to be proactive and to shift the mindset. But our society doesn't value the lives of people with IDD. I mean, it's really quite criminal. And that's what I was trying to about. So, like, can CMS, can this group create an assessment tool that values the person, as well as comes up with some assessment, so that we're assessing the environment that we're in, we're assessing that the programs that they're in, and not making the person feel bad. I mean, every time we do these assessments, my kid, who really, in all due respect, is really quite successful in his own way, but he's not made to feel that way. If those assessments, I have to prep him every time. That's my question.
Henry, do you want to take that on?
Well, I can start, and I see Don's ready too, but I think there has been some work done on really putting the person at the center of this assessment process. It is idealistic, I think, at some stage. As it moves through a process, it gets whittled down, modified, and it turns into part of a more traditional assessment, I think, that Leslie's referencing, where really it's more about, gee, are we able to allocate the appropriate resources? Are you starting to reach you've achieved something and we need to take things away from you, instead of really looking at and taking the opportunity. And back to Don's point about CMMI having 2 M's, I want to just go sit with Liz Fowler, who is now the director there, to spend time thinking about how Medicaid really is critically positioned. It touches the social determinants. This really is where our healthcare delivery system is best poised to have some impact on some of the social determinants. And so there's got to be a lot that we could learn there. How that ties back into reforming an assessment, I think those are linked, right? If we're really starting to look at how our service system allows people to, benefit from some of the natural supports that exist in our communities, or invest in the inverse, invest in those places where the social determinants are just falling woefully short, which I think is a large challenge for many of the low income people that rely on Medicaid, particularly the issues around racial equity. When we look into these marginalized communities, they're just so under-resourced that thinking about how the Medicaid program can offer up an appropriate payment, it kind of boggles the mind. But I drifted a bit away, and I think, Don, you had something to add here too.
Well, yeah, I can't. First of all, I'm going to be really narcissistic. I added the second M because I think, I really think it's important what you're saying, Henry. I found Leslie's comments really moving and really important. Measurement is by definition an exercise in reductionism, because you're taking very complex things and putting them into a box or a number. And Leslie, I hope we need to take your words to heart. And it's actually a great agenda for IEC, I must say. Leslie, can I put you on the spot? So let's say, I don't know your son's name, but what is his name?
His name is Joshua.
So suppose we focused on what really matters to Joshua. Even if you can't get us to a metric, what would be some of the words you'd use that would describe what we should be looking for to support success for Joshua?
Autonomy, having choices, being respected in the community, having the supports that allow him to engage in the activities that he wants, having a job that is meaningful. That's some of them.
Wonderful, just wonderful. Imagine a system to be developed to accountable for that, where we would find a way to know through proper questioning and dialogue with Joshua and you about whether we really were getting there. That's the kind of holistic thinking that we really need, and it's really hard to take, a system schooled on numbers to what actually matters.
Yeah. So I mean, Josh uses the self-direction model through OPWDD, and it's really opened up the world for him and given him all of those things. The pandemic, of course, shut things down, and he's a little bit of a tailspin, but he's coming out of it. He got his hair cut yesterday for the first time. He has great support staff that worked with him to understand, to make a decision about where to go and to help him navigate going to a new place. Self-direction is a wonderful model. How can that be sustainable? Because somebody else had posted something about the consumer direct, so the CDPAP models, those are great models. How can we make them sustainable without making them institutional?
And Leslie, I think you have underscored the very important points that Don and Henry made about creating systems focused on the whole of the person. If we built a system for Josh in the mode of targeted universalism, how many more people would benefit from a system that really at the end of the day was measuring how they can live their fullest lives, as opposed to checking other boxes. I think you've landed us back exactly where we wanted to come out with this conversation with our two esteemed thought leaders. And I hope you all will join me in thanking them for their time and their contribution to this very, very important discussion today. With that, I want to turn this back over to Mai for some closing comments. And I know she wants to thank all of you for being present for this discussion. And Mai, back to you.
Thank you so much, Susan. Thank you so much to Henry and Don for showing up and being yourselves and those beacons that we've come to expect you to be. And I think this afternoon has exceeded my expectations because we got together this remarkable group of really committed people and we heard your voices. And more importantly, you had a chance to hear from each other. I think it's been very affirming, and we would love to follow up with you individually to share a little bit more about some of the specific things we're working on that touch on what interests you. And Leslie, we will be coming at you with a whole bunch of ways that we can get you involved and get voices like yours and your sons into the work. But just want to leave you with the invitation that we'd like this to be the beginning of your engagement with the IEC community, and that this is a build. This is a startup and a build, and the people who are there in the beginning leave the deepest fingerprints. So can't wait to get all of those pressure points from you, and we will be in touch. Thank you so much.
Thank you.
Take care.
Thanks, everybody.
Thank you, everyone.